Welcome to the EAU podcast on prostate cancer indication for biopsy and screening. Today we are joined by Roderick van den Bergh, a clinical urologist in Erasmus MC in Rotterdam, the Netherlands. Also Erik Briers, the vice chairman of Europa WOMO, the European umbrella organization of prostate cancer patient organizations, in Antwerp, Belgium. Together they will discuss screening, changes in diagnostic algorithm, prostate biopsy, and patient perspective. Join us as we embark on this informative journey.
Welcome to this podcast by the European Association of Urology. Today we will discuss different topics all related to prostate cancer, including screening, changes in the diagnostic algorithm, prostate biopsy, and of course the patient perspective. I am Roderick van den Bergh.
And I am Erik Briers.
Erik will first discuss the current status of screening for prostate cancer in Europe, followed by awareness for prostate cancer by men in the European Union. Afterwards, I will discuss the recent developments in the diagnostic algorithm related to MRI and prostate biopsy. And finally, I will try to discuss how these changes in the diagnostic algorithm may impact the feasibility of screening in Europe. And then we will discuss, of course, the patient and urologist perspective to conclude. Erik.
So if we want to look at the situation that is actually in Europe on, let's call it an early detection of prostate cancer, we have to admit that in most of our countries there is no screening program. Nothing is organized. So it's up to the patient to go to his general practitioner and ask for a PSA test, which is not an optimal strategy to do early detection. That has been proven by studies. Now, on the other hand, we did have some excellent clinical studies on the use of PSA testing, like the ERSPC study, which showed clearly that after a number of years, like 13, 15, you had a considerable drop in the overall survival if in the group that did not have a PSA test. So it was much better for those patients who did have a PSA test not to die from prostate cancer. At this moment, we are moving into a new situation where screening for prostate cancer is really looked at in the PRAISE-U studies, where in different countries a number of pilots are being done, just to find out how could we organize an effective, risk-based and population-based screening in Europe. So in Europe, if we look at the past, a lot of opportunistic testing was done, and this came with the side effects that quite a few of the people who went for just a PSA test were overtreated and were also overdiagnosed. And to prevent this, that's the importance of having a risk-based strategy to find and to screen for prostate cancer. So if we talk about awareness of men on prostate cancer, that is something that is not very high in Europe. It's even so that a lot of men don't even know that they have a prostate, let alone that they know what it's for and where it's situated in their body. So there's a need for a real program of education for men to learn them about the prostate. Because being the first cancer for men, it's important that they know what it is, where it is, but especially how it can be found and what can be done about it. Now, for men, once they know what the prostate is, they are aware and they can act accordingly when they reach an age where, due to that age, which is a very important risk factor for their prostate cancer, that they can have a PSA test which is very simple and very inexpensive, to be followed by other tests if something shows to be wrong. Now, this is very important because there's a second group who does know what the prostate is, where it is, what it's for, and these are the general practitioners. And what we as patients see is that some of these GPs, not all of them, also not well informed about the possibilities of the PSA test and how to handle it, and they refuse testing for some patients who ask for it and who are really at the right age, etc. One of the common misunderstandings among men, and sometimes that's the first time that they think of their prostate, is when they have a problem urinating. They think that if they have difficulty urinating, they think that they have prostate cancer, but there is absolutely no link between the two. And they need to know that, because they would then go very scared to the doctor to be informed that they have no prostate cancer. Of course not. One of the things that we have to move away from is the idea that a PSA that is elevated is a sign of prostate cancer. It is absolutely not. And in modern screening algorithms, we follow on a PSA test with other tests like MRI and like will be described after me. So it is extremely important that the patient knows that an elevated PSA is only a first step in a diagnostic process.
I think it's very important to realize that we have come a long way since the first screening trials have been initiated in the early 1990s. For example, ERSPC, the European Randomized Study of Screening for Prostate Cancer, applied a state-of-the-art protocol in those days, which included doing a prostate biopsy when PSA was elevated or an abnormal digital rectal examination. No imaging was involved, and the prostate biopsy was a sextant lateralized prostate biopsy, so no targeted course. We have also learned a lot about which age groups to invite. Screening in the elderly, so above 70, dramatically increases overdiagnosis, while the impact of screening in reducing prostate cancer mortality is limited. There are also different ways to identify risk groups using family history or even genetic predisposition. Very basic knowledge, such as the predictive value of PSA density, was not available at the time ERSPC was initiated. And other improvements can be found in the re-screening interval, which was a fixed 4-year interval in ERSPC. But now we learned, and which is a quite dramatic improvement, that men who are low risk after the first screening, so with a PSA below 1, can be re-invited after 4, 5, or even 6 years, while the higher risk men with a PSA between 2 and 3 should be invited after 1 or 2 years already. And this reduces the overdiagnosis rates and the burden of a screening protocol. Very important improvements, of course, have also been applied in the diagnostic algorithm for the suspicion of prostate cancer. Most of the studies were done in a clinical population, but these can be, of course, also applied in a screening situation, and we can expect the same improvements. The main ones are, of course, the indication for prostate biopsy, which is dramatically improved by doing an MRI before deciding on a biopsy. By applying that MRI, the number of unnecessary biopsies is reduced dramatically. And other ways to do this is using risk calculators, which combine the different clinical parameters into a risk estimation to do that biopsy, yes or no. And this may be one of the most important decisions in the diagnostic algorithm. These tools can also be sequenced, for example, doing a risk calculator first before moving on to doing an MRI, which reduces the number of unnecessary MRI scans. And finally, the biopsy approach has changed because we did transrectal biopsies initially, which gave quite a significant chance of infection or even sepsis. But now many countries and centers have moved to transperineal biopsy, where we can take prostate biopsies without the risk of an infection, and even antibiotics are no longer required before this procedure. The biopsy strategy has, of course, also changed due to the availability of imaging and MRI of the prostate. While we did systematic biopsy sampling initially, we now have targeted biopsies aimed at lesions in the prostate. This increases the number of cancers labeled as significant. This can either be due to cancers found that were initially missed, but we should also be careful for a stage shift where we sample the same tumors, but now more in the aggressive zone of the tumor, which gives an artificial upgrading of the disease. So I try to give you some examples here of how our diagnostic algorithm, both for a clinical situation but also for a screening situation, have improved since the first screening trials were started. All these improvements are very likely to maintain the effect of screening in reducing prostate cancer mortality, while it's very likely that it will reduce the main side effects of screening, which is, of course, overdiagnosis and the diagnosis of low-risk Gleason 6 tumors with a risk of overtreatment and side effects. So while many people and policymakers still quote the numbers found in studies started 30 years ago regarding prostate cancer mortality reduction, but also overdiagnosis, it is very likely that when a new screening protocol would be introduced now, the side effects of such a protocol would be dramatically reduced. And I will give you an example here because Jonas Hugosson in Sweden published a study in New England Journal of Medicine where MRI was applied in a screening situation and the number of overdiagnosed Gleason 6 tumors was reduced by more than 50%. And another important point I forgot to mention so far is, of course, active surveillance. Because when the early screening trials were performed, most tumors received active treatment. In those days, expectant management of low-risk tumors was not done. And active surveillance now has broken the link between diagnosis and treatment, trying to postpone or preferably avoid treatment in men who have been diagnosed with an indolent tumor that would not have caused any trouble even when remaining undiagnosed. So active surveillance is, of course, an essential point how our algorithm for diagnosing and treating prostate cancer has improved as well. However, despite all the improvements mentioned, there are many other factors that should be taken into account before a screening protocol can be applied on a population level. Countries should be ready to apply this. People in the country should accept an invitation for screening. All the tools necessary, all the requirements from a healthcare perspective, nurses, urologists, radiologists, there should be availability of all these resources before such a protocol can be successfully implemented. Since the diagnostic algorithm has improved, it also has become more complicated, and quality issues, for example, for radiology review of the MRI, but also for urology targeted biopsies have become, more urgent. So these issues should also be solved before screening can be applied in a country. And this is exactly what the Praise You project is aiming to achieve, to study what the impact would be of implementing a modern screening protocol in a specific country regarding the issues of acceptance, availability, to calculate what the feasibility would be in a population setting. So although we learned a lot on how to diagnose men with prostate cancer, to select the correct risk groups, and all the improvements in the diagnostic algorithm that have been mentioned before, screening is more than just inviting somebody to have his PSA done. There are a lot of logistical issues that should be solved before such a program can be successful.
Now, to proceed with getting this screening done, we first of all have to increase the awareness by European men and their partners on prostate cancer so that they know that there is a possibility to go into a program of risk-based, population-based screening, which will in turn give them then the information they need on eventually having prostate cancer. And we should never forget that it is cancer that is very prominent, but it is touching 1 in 7 men. So 6 in 7 will not have prostate cancer, but you need to know this before you can act on it.
So to conclude my view from a urologist perspective on screening and on modern screening using a sophisticated diagnostic algorithm is that I think many of our colleagues have been educated that screening has more side effects than advantages. And I think that we should all, dive into this issue again, finding the correct numbers regarding prostate cancer mortality reduction and overdiagnosis with such a new screening protocol. And then if the logistical issues are also solved, I think that most of us will accept introduction of a screening program on a population level for prostate cancer. And then we will have a dramatic impact on the number of patients that we see every week who are 60 or 65, have a PSA of 30 or 40 and newly metastasized disease. And we should all remember that screening has a potential to reduce that on a population level of 20%, but maybe on an individual level, it may be 30, 40, or even 50%, as has been suggested in studies from Rotterdam. And with that, I want to conclude. I want to thank my co-presenter, Erik Briers. I hope that you found it interesting, that you learned something on screening, the new diagnostic algorithm, prostate biopsy, and how screening could be successfully implemented in the near future. Thank you for listening and have a nice day.
So thank you for now. It was a pleasure to talk to you about screening, early detection. And I hope that you, if you're a man, that your results will be negative.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.